let's get started talking about cardiac arrhythmias. Now, this is a vast topic because we can have atrial arrhythmias, ventricular arrhythmias, but one thing I can assure you is they fall beautifully into the matrix. So when we think about arrhythmia, we have to think about the genetics. Does someone have a long QT syndrome, which can cause a malignant ventricular arrhythmia? Does someone have the genes for atrial fibrillation? And so on. So we have to think about the matrix in terms of every aspect of arrhythmia. So for example, you might say, how does assimilation fit in? Well, if I'm not digesting properly, if I'm not getting my nutrients, I'm going to have a deficiency of intracellular magnesium. I may have a taurine deficiency. I may have a deficiency of potassium. All of that, of course, can lead to arrhythmia. And then we all know that the more hypertension we see, the more arrhythmia we see. We know that the more sleep apnea we see, it's completely linked to arrhythmia. Anything that can impact ventricular size, cardiomyopathy, anything that dilates the left atrium, all can cause arrhythmia. But what many people don't realize is that food sensitivities can cause arrhythmia, stress can cause arrhythmia, and we saw that big time with the research coming out of 9/11, where people's AICD devices were going off, and there was a much higher incidence of ventricular arrhythmia. So every aspect of the matrix, from ruling out sleep apnea to getting people exercising to their ideal weight, which, by the way, treats sleep apnea and hypertension, both of which are linked to arrhythmia. Nutrition, right? Too much sugar in the diet and processed foods have been linked to arrhythmia. Deficiencies of omega-3, of potassium, of micronutrients linked to arrhythmia, and stress linked to arrhythmia. So lots of reasons for us and many to focus on arrhythmia, but many things that we can do. We can decrease inflammation. We can deal with mitochondrial dysfunction. We can deal with insulin resistance, diabetes, and thyroid dysfunction. We can treat hypertension. We can treat sleep apnea, and that's going to affect everything from structural integrity, communication, energy, defense, and repair. It's everything we talk about. What are we going to do from a testing standpoint? If someone says to you, I have an arrhythmia every day, then you're okay to put on a traditional 24 or 48-hour heart monitor. If they say my arrhythmia is occasional, it's once a week, then you want to put on something more like a Zeo patch, a form of an event recorder, which allows you to record for 7 or 14 days, and that's all wireless. If someone has an arrhythmia that you just can't pick up, that you've tried with event recorders and you're still missing it, you may want to put what's called an implantable loop recorder in, which is a little device that goes under the skin. And some of that, of course, we're going to leave to my cardiology colleagues to do. So a lot of it depends on what the patient says, what kind of symptoms they have. And it's important to remember that someone who says, I faint when my heart goes fast, that person goes straight to the cardiologist. Or I can't breathe when my heart goes fast, or I'm short of breath, or I get chest discomfort. We want to get this person properly referred because there's a chance that they may be having an arrhythmia from Wolff-Parkinson-White, or from a rapid AFib, a flutter, or AV nodal reentry tachycardia, or right ventricular outflow tract tachycardia. So we want to get these people taken care of. Once we have identified what we're dealing with, we have lots of options. So there are, of course, many pharmaceuticals, the basic ones being beta blockers, calcium channel blockers, common beta blockers, metoprolol, for example, calcium blockers, verapamil or cardizem. These are for our basic arrhythmias, gee, I feel a few skipped heartbeats, or occasionally I get an extra beat or skip and a jump. But I really think we can treat that with a functional medicine approach. Cardioversion, that's of course for someone who has a fib or a flutter, and we can't get it under control with medications. We might have to do a cardioversion. And then of course there's catheter ablation, and then ultimately surgeries where we tie off the left atrial appendage, or we do some surgical cuts in the left atrium. There's only one thing I'd like everyone to know about here, which is something called a Watchman device. If you have a patient that has atrial fibrillation and they cannot take anticoagulants, their AFib may be totally controlled, nice slow heart rate, 70 beats a minute, not a problem, doesn't bother them, but they can't be anticoagulated, you might want to think about doing a Watchman, again, referring them to a cardiologist. That's a little device that goes in the left atrial appendage. From a functional medicine standpoint, there's so much that we can do, because the most missed arrhythmia is the one that's linked to sleep apnea. So ask those questions about sleep apnea. Do you wake up at night? Do you feel tired during the day? Do you wake up with a headache in the morning? Do you snore? Does someone complain that you stop breathing? You can do a quick assessment for sleep apnea. And it's very easy today to get a home sleep system, a watch pad, a night owl, some system that allows you to do a sleep study completely disposable in somebody's home. You also want to think about hypertension, because hypertension remodels the heart, and hypertension causes left atrial enlargement, which predisposes people to not only simple things like APCs, but more aggressive arrhythmias like atrial fibrillation, for example. Stress, which we talk about in a separate section and is near and dear to what I love to talk about, the stress hormones, adrenaline and noradrenaline, absolutely speed up the heart. You know this, they speed up the heart, they cause the coronaries to constrict and are linked to arrhythmia. People under stress have more atrial fibrillation, they have more ventricular tachycardia, and that has been proven. The other piece here that I'd like to mention that didn't get added to the list is thyroid hormone. Many of my colleagues like to give high doses of T3. T3 is free thyroid. And T3, I cannot tell you how many consults I have done for arrhythmia from people on high doses of T3. And when I pull back the T3, I treat the arrhythmia. So when you think of hormones, think about the stress hormones, but also think about thyroid. And of course, if you draw someone's blood and the thyroid is high and they're not on hormone, you want to think about Graves' disease, and you want to look at antibodies to the thyroid receptors. So those are some of the basic principles. When we go into nutrition, many people have arrhythmia related to dark chocolate. And the patients always say to me, oh, dark chocolate's good for you. Well, it can cause arrhythmia, just like caffeine can cause arrhythmia. Some people are slow caffeine metabolizers. The other genetic issue is the COMT, right? Catecholomethyltransferase. Some people have a sluggish COMT and they cannot break down their adrenaline and their noradrenaline. These people, we have to think about cleaning out all their caffeine, dark chocolate, tea, coffee. That's a good place to start. And coffee, of course, and caffeine can lead to dehydration in some people, not in everyone, but dehydration will cause arrhythmia, because remember, cardiac output is stroke volume and heart rate. And if you're dehydrated, you're going to increase your heart rate and you're going to have more extra beats. Alcohol, excess alcohol is linked to what we call holiday heart and atrial fibrillation. And if a patient doesn't admit they're drinking excess alcohol, you can usually tell. Their MCV may be high on their CBC. And you may do a BIA and find a lot of extracellular water. Sometimes there are clues, and of course there are LFTs that might help us there. Mineral deficiencies we'll talk about in a few minutes. And of course, changes to the chest. Does someone have kyphoscoliosis? Some people get arrhythmia when they lie on their left side. So opening the chest up, changing someone's posture, teaching someone pranayama, how to breathe. I love the new book, Breath, right? How do we breathe to expand the lungs and open the chest is fundamentally important for our patients. So from a functional medicine approach, certainly we always measure somebody's omega-3 levels, and I always do a NutriVal to look at nutrients. And I want to keep the potassium level above 4.0. 3.5, even though the lab says it's normal, it's not normal when it comes to arrhythmia. And I want to replete what is linked particularly to arrhythmia, but replete in general. I will start magnesium immediately. I will start magnesium chelated form, 500 milligrams at night. And if their stool doesn't get too soft and they can tolerate it, I'll go right to 500 milligrams in the morning. It is a magic bullet. Magnesium and hydration and potassium are magic bullets for me, my patients, for correction of arrhythmia. And then you want to look at selenium and copper as well. And of course, we're going to replete our vitamin D and our antioxidants based on the data that we have. I want you to also think about not only alcohol as a toxin that causes arrhythmia, because that is really what alcohol is. It is a toxin and it's an energy source. And when people drink a lot of alcohol, they don't use the food they eat for energy. They use the alcohol as an energy source. Alcohol is linked to AFib, aflutter, ventricular tachycardia, APCs, VPCs. So really doing a good screening for how much alcohol someone is drinking is important. Food sensitivities are important because if someone has a lot of gas, a lot of bloating, the heart and the gut are sitting very close together. So we have to think about that as causing arrhythmia as well. So let's think about functional medicine testing. From our nutrient analysis, we can really understand intracellular magnesium, potassium, all of our minerals, all of our antioxidants. Vitamin D we can measure very easily. We can do an omega check. We can then replete all of our vitamins and nutrients, minerals as needed. From a nutrition standpoint, we want to make sure that we get rid of the excess caffeine, the excess alcohol, and that we maintain adequate hydration in our patients. And for some of my patients, particularly people with arrhythmia of all types who run a low blood pressure, I will add electrolytes to their water to bring their blood pressure up. So these are some of the fundamental ones. Of course, we get our magnesium from our green leafy vegetables. Magnesium, again, is a magic bullet, not only for treating the bad boy Torsade de Pomme, but it also treats APCs, of course, VPCs, and we get plenty of magnesium from our greens. We get lots of magnesium from our legumes, our nuts, our seeds, and this is all in keeping with our cardiometabolic food plan. For electrolytes, my trick is to give potassium in the form of a powder, 550 milligrams added to water for people who have high blood pressure, because it will help to lower the blood pressure and it will help with the arrhythmia. I still give magnesium as well. For people that run a low blood pressure, those people that have a blood pressure 90 or 100, I give them a mixture of electrolytes to bring their blood pressure up. I like to get my omega-3 checks into the normal range, depending on the lab you're using. So I will then replete accordingly the omega-3s. And then we have from our NutriEval, of course, we're going to know where are we at with our folate, where are we at with our B12, where are we at with our antioxidants like lipoic acid, where are we at with taurine, and so on. So these are just a few of the nutrients that we can replete. And of course, CoQ10 has the advantage based on Mortenson's data in people with class 3 and 4 heart failure, systolic heart failure, of improving heart function, decreasing hospitalization, and decreasing morbidity and mortality at 300 milligrams a day. So again, we take a look at the whole person approach. Is someone getting the nutrients that they need? Is their gut working? That's always my first stop. What's going on with the gut? And many patients say to me, you're a cardiologist, why do you care about the gut? And I have to say, well, if your gut is not working right, you're not getting your magnesium, you're not getting your potassium, you're not getting your B12. Maybe that's why you have osteoporosis, and so on. And then, of course, we're going to order some blood work, which is going to be looking at thyroid function. And I always do a free T3 and a free T4, and I do thyroid antibodies because I'm interested in knowing if this person has Hashimoto's disease. So those are basic. So intracellular magnesium, potassium, and a full thyroid panel, then a full NutriEval, if you can get one. That would be very, very helpful, because we have seen, for example, with hypertension, just repleting back the nutrients, you can get people off of their blood pressure medication. So the approach for arrhythmia is really one that allows us to bring in nutrition, eliminate some of the causative agents like alcohol, like excess sugar, check for food sensitivity, replete the nutrients, get the blood pressure corrected, check for sleep apnea, and it really gives us the opportunity to transform someone's arrhythmia in a very powerful way. So thank you.
Thank you, Dr. Guarneri, for that enlightening talk. Now we'll go over COVID considerations, the RAAS system, and bradykinin. Our agenda: first, we are going to review the RAAS system and describe how it's disrupted by SARS-CoV-2. So let's look at the commonly understood RAAS physiology. Angiotensinogen converts the angiotensin 1 through renin. Angiotensin 1 becomes angiotensin 2 through ACE. And then you have the angiotensin 2 working on receptors in particular, and one of the main ones is the AT1 receptor. And that leads to vasoconstriction, proliferation, inflammation, a pro-fibrotic effect, thrombosis, and oxidative stress. ACE inhibitors work here. They're going to stop angiotensin 1 from converting to angiotensin 2, and ARBs are going to work at the receptor level. They're going to stop angiotensin 2 from binding in on the receptor. And this is going to be important. You'll see why later in dealing with COVID. Now, there's a piece to the physiology that is not much spoke about until now. If you look at the literature, there's information on ACE2, but this devastating pandemic that has been completely changed our world for generations to come. If you look at what it does, is it affects ACE2. ACE2 was known about for research, but it's not something we looked at too much because there weren't any drugs that modulate it. But let's look at what ACE2 does. ACE2 is going to convert angiotensin 1 to angiotensin 1,9, and it can also convert angiotensin 2 to angiotensin 1,7. And the angiotensin 9 from the previous can become angiotensin 1,7. But bottom line, what it ends up doing is it takes that angiotensin 2 that could have caused this ill effect, and it gives the opposite effect. It makes it have a vasodilatory effect, an anti-proliferation, an anti-inflammation, anti-fibrotic, anti-thrombosis, and antioxidation effect. So it does the opposite of what angiotensin 2 does if it binds to the ACE or the AT1 receptor. And basically, both of them are good, both of them are needed, but they need to be in balance. And if the balance is off, it is going to result in worsening outcomes if you get COVID-19. If you look at this, low ACE2 is going to result in vasoconstriction, proliferation, inflammation, a profibrotic effect, thrombosis, and oxidative stress. And COVID, the SARS-CoV-2 virus, is going to knock out a lot of your ACE2 receptors. So if you look at Atom 17 is a piece to this puzzle that may explain partially why certain people do worse with COVID and some people do better with COVID. It's also known as TACE, or tumor necrosis factor alpha converting enzyme. It's a matrix metalloproteinase enzyme. It's activated by, this is the important part, hyperglycemia, oxidative stress, and angiotensin II elevation. All of those things will make this Atom 17 turn on and start doing its thing. And when it's active, this is the important part, when it gets activated, its shedding will lead to a shedding of ACE2. So it's going to get rid of some of ACE2. Remember, COVID is attacking ACE2 and it's going through ACE2 and disrupting it. Now, if you have a lot of Atom 17 activation, you're going to lose more of the ACE2 because it's going to be doing that. But on top of that, it's going to be knocking it off. It's going to make it slough off the cell wall, but it also is it's responsible for releasing tumor necrosis factor alpha, which causes inflammation. And it's actually one of the major imbalances with ARDS, which we see people develop in COVID. So if you're consistently activating Atom 17, you're knocking out the ACE2, and you're going to have this imbalance. You're going to have more angiotensin II and less angiotensin 1,7, which leads to vasoconstriction, proliferation, inflammation, a profibrotic effect, thrombosis, and oxidative stress. Remember, with COVID, part of the problem is the way our body is responding to the virus. The way that we are trying to attack the virus, we overdo it, and it can cause a lot of its damage that way. So what about ACE2 and infection susceptibility and severity? Patients that have low ACE2, it's not as easy for them to catch it, but because of the underlying imbalance that we talked about, they will get more severe disease. Now, patients that have higher ACE2, it's easier for them to catch it because COVID goes and binds to ACE2. That's how it gets in the cell. So it's easier for them to catch it, but when they catch it, because they have lower angiotensin II and they have higher angiotensin 1,7 and 1,9, what ends up happening is that it's more protective, and they basically have less of a chance of having more severe disease. So let's take a look at what we've just covered. SARS-CoV-2 is going to enter, and it is going to enter through the ACE2 receptor. And when it enters the body through the ACE2 receptor, it's going to render the ACE2 inactive. What's going to happen? You'll have lower angiotensin 1,7 and angiotensin 1,9, which leaves your angiotensin II unopposed. So these effects of vasodilation, antiproliferation, anti-inflammation, antifibrosis, antithrombosis, and antioxidation are going to go away. And you're going to be left with this stimulation, this angiotensin II. And infection itself is going to increase angiotensin II. So you're going to have more vasoconstriction, proliferation, inflammation, a profibrotic effect, thrombosis, oxidative stress. Look at our COVID patients. They have proliferation. They have inflammation of the lung. They have a profibrotic and thrombotic effect. They have an increased risk of blood clots. They have lots of oxidative stress. Now, angiotensin, if you look at that AT1 receptor and what angiotensin is doing, it also, the oxidative stress and the angiotensin II is going to activate Atom 17. And when it does that, it's going to slough off ACE2. So now you have even less ACE2. It also is going to slough off tumor necrosis factor alpha, and it's going to, or pro-tumor necrosis factor alpha, it's going to release tumor necrosis factor alpha. And what that's going to do is that is going to increase inflammation and push you towards ARDS. So our second agenda item is to discuss bradykinin activity in the lung and how dysregulation of bradykinin may contribute to the pathogenesis of COVID-19. So there's another hidden link here. Bradykinin is part of the kinin family. It's a family of vasoactive peptides. It exerts its effect through B1 and B2. So the two, bradykinin 1 and bradykinin 2 receptor stimulation. So bradykinin directly is going to stimulate B1, and bradykinin through its metabolites, through what it breaks down to, can stimulate B2. It causes vasodilation. It causes increased vascular permeability. So blood can leak into tissue much easier, and it's going to cause an increase of inflammatory mediators. So it's going to increase inflammation. It plays a role in healthy physiology and many disease states, including septic shock, pancreatitis, and hereditary angioedema. It's broken down by ACE. So that original ACE that ACE inhibitors work on, that's what breaks down bradykinin. And its active metabolites are broken down by ACE2. That's where we're thinking it is playing a role in the pathophysiology of COVID-19. So take a look at this graph. ACE is, which ACE inhibitors work on, is responsible to break down some of the bradykinin. Some of the bradykinin is going to stimulate bradykinin 1 receptors, and when it does that, it will lead to vasodilation and increased vascular permeability. ACE2, so some of the bradykinin will end up converting or breaking down to des-ARG bradykinin, one of its active metabolites. And what that will do is it'll stimulate beta-2, or not beta, but bradykinin 2 receptor stimulation, leading to vasodilation and increased vascular permeability. SARS-CoV-2 is going to block ACE2, so it's going to stop the deactivation of des-ARG bradykinin. So there's more des-ARG bradykinin left, which can stimulate beta-2 receptors. So this COVID seems to now increase the bradykinin that's hanging out in the lungs. So the imbalances that we discussed so far related to COVID-19 pathogenesis: increase angiotensin 2, decrease angiotensin 1, 7, and 9, increase TNF-alpha, and an increase in bradykinin metabolites, all of which will turn into increased perfusion, which can lead to ARDS, severe endothelial dysfunction, which can lead to thrombosis, hypercoagulation, which also is thrombosis, and inflammation, which can lead to cytokine storm and ARDS. All the nasty things that happen with COVID, that's basically what we just discussed. All of them can be explained by this. Our third agenda item: explain how to potentially modulate the RAAS and bradykinin system in relation to COVID-19. So why might ACEs and ARBs be helpful when dealing with COVID-19? Why would we think that they're helpful? Well, ACE inhibitors are blocking angiotensin 1 from becoming angiotensin 2. And if you have less angiotensin 2, remember, angiotensin 2 being high is one of the reasons that people get really sick with COVID-19. ARBs are going to work right on the receptor. So they're going to stop stimulating the AT1 receptor, and it's going to block all of these negative things that are in the red. It's going to decrease the amount that happens. So what's the deal with ACEs and ARBs and COVID-19? Early on, when the pandemic first started, people were getting very worried about ACEs and ARBs. They said ACE and ARBs may increase ACE2, and because ACE2 is the way that COVID enters the human body, it's going to increase infectivity. We need to stop them. And then some people went nuts and they said, all right, well, we need to stop vitamin D too, because vitamin D also is going to increase ACE2. And they went all just in a crazy direction. Research is still being conducted, but it does not seem like the ARBs and ACE inhibitors cause a negative effect. On the contrary, they probably help, but we're not sure yet. We got to wait for the research to come out. What we recommend at IFM is following the AHA ACC guidelines when it comes to this. And basically what they're saying is to continue to use the RAAS modulation treatments according to standard clinical practices. So if somebody has hypertension or diabetes or whatnot, and you want to put them on an ACE and an ARB, continue to do that. Don't take people off of it and continue to put them on it. Here's the thing. My belief is that ARBs may be better than ACE inhibitors. And there's some research to support this, and there's some theories behind this, but I'll tell you why. If you remember, ACE inhibitors, if you look at the red arrow there, ACE inhibitors are going to block ACE. And what ACE does is ACE is going to stop it's going to break down bradykinin. It's one of the pathways that bradykinin gets broken down. So if you give somebody an ACE inhibitor, their bradykinin goes up. Remember, when people go on ACE inhibitors, they get a cough. It's called the bradykinin cough. And some people, especially African Americans, are more susceptible to having this angioedema, this life-threatening swelling when they go on ACE inhibitors, because of the susceptibility to higher bradykinin. So now if we give them an ACE inhibitor and we think that bradykinin may be playing a role in the pathogenesis of COVID-19, then maybe there's another way, and there is another way. So bradykinin will lead to vasodilation and increased vascular permeability, like I said, which can worsen COVID-19. So now SARS-CoV-2 is going to then knock out ACE2. So now you put them on an ACE inhibitor, and there's higher amounts of bradykinin, and then you knock SARS-CoV-2 is going to knock out ACE2, so you get less of the metabolite breakdown, and you get more of the DES-ARG bradykinin, which is going to stimulate the B2 receptors or the bradykinin 2 receptors, which can increase vasodilation, increase vascular permeability. So it's like a double whammy. I personally have been changing my patients from ACE inhibitors to ARBs. So as mentioned, ARBs may be better than ACE inhibitors due to their impact on bradykinin. There was a large population study of about 1 million people that showed that people that were on ACE inhibitors for some time had a higher risk of lung cancer. And the longer you were on an ACE inhibitor, the higher the risk. It may be like a bradykinin effect, who knows? But ARBs did not show that. What I would say is take a look at telmisartan. And the reason for this is it has a longer half-life. It binds tighter to the AT1 receptor. It can cross into the blood-brain barrier. So this is one of those blood-brain barrier crossing ARBs that may decrease our risk of dementia. And it may increase the production of ACE2. What happens after COVID is that you got people that have hardly any, their ACE2 has been knocked out and they're stuck in this pro-inflammatory, pro-fibrotic state, pro-oxidative state. So what are some supplements that we may potentially be able to use to modulate the RAAS system and the bradykinin system? Well, vitamin D3, because it can decrease renin, it can decrease ACE, and it can decrease angiotensin 2, and it can increase ACE2. NAC, or N-acetylcysteine, it's a powerful antioxidant. It increases glutathione. Alpha-lipoic acid, because of glucose regulation, and it's an antioxidant, it has antioxidant activity. Curcumin, because it can potentially upregulate ACE2. It's anti-inflammatory, and and the big part of its anti-inflammatory nature is lowering TNF-alpha. And melatonin, because it's anti-inflammatory and it can also lower TNF-alpha, and it has antioxidant properties. So there's so many supplements you can take. I kind of narrowed it down to these. I feel like these are the most important, not in COVID, but just in the physiology that we've just discussed, that part. Forget about antiviral mechanisms and whatnot. And the good news is if you look at these supplements, they're going to have other mechanisms, but I just focused on what we talked about here. Now, let's try to kill 2 birds with 1 organic stone. Why an organic stone? Because we are functional medicine and we do organic. And if I'm going to throw a stone at a bird, it better be an organic stone. So N-acetylcysteine has been found helpful in COPD, hyperhomocystinemia, bipolar disease, and hyperlipidemia. So if you have a patient with these things, it may be good to put them on NAC, especially in this pandemic. Alpha lipoic acid may help with diabetes and diabetic neuropathy, hyperlipidemia, and there's data that shows that it helps with weight loss or fat loss. So if you have a patient that has these things, consider alpha lipoic acid. Curcumin may help with depression and hypertriglyceridemia and non-alcoholic fatty liver disease, and osteoarthritis and pruritus. So someone itching and you don't know why they're itching and you're like, man, try some curcumin and it may protect you against COVID as well. And melatonin, if you have people that have reflux, melatonin can help because it can strengthen the lower esophageal sphincter. It can help with if they're having sleep issues. And remember Dr. Stone's lecture about doing 24-hour blood pressures and how some people don't dip at night. Well, guess what? Melatonin makes you dip. And dipping is good when it comes to blood pressure at night. Here is some guidelines in starting the supplementation. I mean, do your own research. I put this slide here for a couple of reasons. One, just to give you a guideline on the dose that you can start with. Also to show you the side effects, because you know what? Just because it's a supplement doesn't mean that it doesn't have side effects. So when you put them on a supplement and they mention a side effect, you can tell, hey, this is a common side effect of the supplement. It's not. And then possible drug interactions, because we got to be aware of this. We have to look at this, and that doesn't, if it has an interaction, that doesn't mean don't use it. It just means be cognizant of what you're prescribing. Pick certain supplements that you prescribe often and make sure you understand them very well. Interactions, make sure that you know side effects. And here, this is, like I said, it's not complete. It's just a place to start. I know what you're thinking. You're probably thinking, man, I want to know more about this. I want to study this more. The good news is we have a course. So check out our course, our IFM's COVID-19 course. I'm one of the faculty members. Also stay tuned, because in the future, in a little bit, Dr. Stone is going to talk about post-COVID syndrome. What do you do with these patients that have COVID and they fight COVID and the COVID is gone, but they are feeling horrible. They're now like a functional medicine train wreck, the thing that we love dealing with. Those patients that can't get better anywhere else. No one else is giving them guidance. Guess what? We got guidance. So stay tuned for Dr. Stone's lecture on that. Thank you very much.
Welcome back. Okay, we've been monitoring the chat rooms and we kind of have some understandings of some wonderful themes going on. It seems like there's WhatsApp groups forming, social health communities, resilience. There's also potentially some chatter that Yusuf and I do not get along. That can't be further from the truth. Just want you to know I am the big sister and he is the little brother that sometimes says things that I must correct, but we get along famously like siblings do. All right, now that that's cleared up, why don't we get to some Q&A? So we learned so many wonderful things in that last segment, and there's probably some burning questions that people have. So I would like to kind of be the voice of what kind of the primary care doctor who's sitting here learning this stuff, wondering, now what? So let's start with you, Michael. So with congestive heart failure, I definitely get that there's a group that has reduced ejection fraction and then those that have preserved ejection fraction. So my question is that, so if they have preserved ejection fraction, is there kind of a difference in terms of like why would they have CHF if they have preserved ejection fraction? And what would be the cause or common causes we should be looking at as opposed to the reduced? Like, should we be looking for different root cause based on if they're preserved versus reduced ejection fraction?
That's a great question. I guess in primary care, first you try to decide whether they are in congestive heart failure at all. And so the tools that we use, of course, are if you look at their respiratory rate, you look at their heart rate with movement, you look at decreased physical activity. And the thing, especially in this time of COVID, is you want your patients who have had CHF before, you want to make sure they have a home scale that works so you can follow daily weight, and you have them get an oxygen saturation monitor with a waveform. Because congestive heart failure, once you if you determine whether they have reduced or preserved ejection fraction by echocardiogram, then your choices and maybe your leveraging of therapeutics change. So reduced ejection fraction, if they have a reduced ejection fraction, frequently you will use more of a ACE inhibitor. You may have a different choice and titration of diuretics, because you can't let them get too volume depleted, or with a reduced ejection fraction, you have different complications. With a preserved ejection fraction, then you have to ask yourself why somebody whose ejection fraction is great, why they're in congestive heart failure at all. And that ties in immediately with Dr. Guarneri's lecture on, do they have an electrical issue, a rhythm issue, AFib, where you frequently have preserved ejection fraction, or do they have a plumbing issue? So think of atherosclerotic disease, or do they have a pump issue? And I think that's the big question for all of them. So just generally in primary care, you're going to follow their weight, you're going to make sure they oxygenate well, you get an echo, and as Dr. Guarneri talks about, you make sure that there's not plumbing-induced injury. From a functional medicine standpoint, you're going to consider different aspects of the matrix in their CHF even. Is it a structural issue? Is it an inflammatory issue? Is it an energetic issue? Since there's a lot of congestive heart failure, when you have congestive heart failure, frequently you have decreased ATP production within the heart. And so you have to think of ways that you can support mitochondrial function.
Okay, so let me summarize to make sure if I'm tracking and if our attendees are tracking. So the first thing to note is you got to diagnose CHF, whether they're known and you want to see if they're getting better, worse, or the same. You're using the scale and an O2 monitor with waveform to just track them. But if they're new, you want to also get an echo to put them in the category of preserved versus reduced or restricted ejection fraction. Right. Then the next order of business is to say, okay, well, if you have preserved ejection fraction, could there be an arrhythmia going on? Could there be a pump issue, a valve issue, a plumbing issue? Like, why?
That's right.
Is it related to the mitochondria? Is it related to the inflammation? Okay, so let's just say it's related to the mitochondria. What are your top effective actions you take if you suspect it's a mitochondrial based reason for why their pump is not working effectively?
CoQ10 for electron transport system, magnesium, usually as a glycinate or a chelate of some type, as a cofactor for muscle contraction, L-acetylcarnitine to get free fatty acids into the mitochondria, and alpha lipoic acid to decrease the oxidative stress that affect that. And then the last one is essential fats, because you can change the essential fatty acids of the cardiomyocyte within 3 weeks. And if you have an arrhythmia issue, you decrease the chance of arrhythmia. If you have an inflammatory issue, you decrease the incidence of inflammation. So those are the top 5. And so that's very common as a therapeutic trial to see if you can get enough bump. We know from CoQ10, I think Dr. Guarneri's talked about this during her lecture, that you can move somebody from New York Heart Association class 3 to class 2 with 400 milligrams of CoQ10 if it's an energetic issue.
Okay, awesome. So I'm going to say this again. It's magnesium in the glycinate or chelate form, CoQ10, sometimes up to 400 milligrams in order to shift them, just get the mitochondria up to date. I'm just going to put out there that there are other lifestyle factors we could use to improve mitochondrial status, whether it's exercise, caloric restriction, these kinds of things as well too, in addition to replacing or optimizing nutrients. And then you said acetylcarnitine, L-carnitine, right?
Correct.
Okay. And did you say anything else? Those are the 3 ones that came to my mind.
Alpha lipoic acid.
Alpha lipoic acid. Thank you. Okay. So that is, oh, yes, Mimi, please add on.
I just wanted to say one thing. going back to what Dr. Stone was saying, preserved EF versus reduced EF, a lot of these things are classic also for reduced EF, where we start thinking about improving the pump, where Mortensen's data on CoQ10 is very strong. I want to add any reduced EF, please, please, please check for sleep apnea.
Yes.
It is a frequently missed cause. And also think about preserved EF as a stiff heart. That stiff heart, frequently from hypertension, arrhythmia, as Dr. Stone said, requires very different therapeutics than does a heart muscle which is weak. On the weak side, we're thinking Coreg, we're thinking Entresto, spironolactone, ACEs and ARBs. And on the stiff side, we're usually thinking, how do I relax this heart? Diuretics, calcium channel blockers, maybe beta blockers. So it's good to think about them in almost two different ways sometimes.
And we're using the echo, just as a reminder, to differentiate, looking at the ejection fraction. Okay, great. Well, let me just segue straight into, thank you, Michael and Mimi, for that. Yusuf, anything else to add as a pearl on how you handle CHF in the primary care setting? Any other things to add? I'm sure you're probably doing a lot of this, but anything that comes to your mind, and you don't have to have anything.
I really like taurine, and I really intermittent fasting and fasting mimicking food plan or diet. It's not really a food plan, that really is a diet. So maybe doing the fasting mimicking diet 5 days for once a month or until they get better. Green tea extract when they're fasting to try to increase their stem cells. And yeah, I think
That's great.
Optimize hormones.
Yeah, I think the thing that Yusuf is bringing up is like, for sure, you want to optimize the heart, but then look at the other systems biology things that you can do to support the heart, just like Michael was alluding to as well, too, with inflammation, with defense and repair, and energy with mitochondria. So Yusuf is just bringing in other aspects of the matrix to support the CHF diagnosis. Okay, awesome. So let's now go to the arrhythmia. Like, look, I've got all these like questions written down. Okay, so Mimi, first thing from a primary care perspective that I'd love to hear from you is, so somebody comes in and they have a history that kind of sounds like arrhythmia. Let's say it's palpitations or dizziness or something. How do we differentiate the arrhythmias that, you know, hey, you could manage this one in-house PCP versus, you know, let's just say it was paroxysmal AFib versus this one's way too concerning for you to keep. You've got to refer out to electrophysiology specialist or a cardiologist to manage. Like, what's the first triage that we do there?
Yeah, so I think one of the first things is, if we go back up to where we always begin in functional medicine and we look at people's history, has this person had a history of myocardial infarction? Is there a possibility that this left ventricle has scar? That's one thing you want to know right up front. The second is, how does the arrhythmia present? Does someone faint? Anyone who faints with arrhythmia, we're thinking about bad things. We're thinking about ventricular tachycardia. We're thinking about Wolff-Parkinson-White. We're thinking about fast AV nodal reentry. Someone is fainting. You want to pick up the phone to an electrophysiologist and say, hey, can you take care of this person? Someone has, I get this arrhythmia and I'm short of breath, or I develop chest pain. So syncope, chest pain, shortness of breath with this arrhythmia, you're really thinking about referring out. And I wouldn't just write, see the cardiologist or the I would pick up the phone and say, hey, I'm concerned about this patient. And what can I do in the meantime? In the meantime, I can order the echocardiogram, right? I can get that done. I can get a heart monitor immediately put on. If the arrhythmia seems to be happening every day, you will capture it in a 24-hour heart monitor. If it's, I fainted last week, but I've been fine ever since, you might need a longer level of monitoring, a 14-day Zeo patch. You might need a loop recorder. Again, that person you are referring out. You can also get right up front an assessment for ischemia. So you can look at the echo. You can do a nuclear stress test for ischemia, or a stress echo, whatever, is available at your center of good quality, you should get blood work immediately. You should be looking, is there hypokalemia? Is the intracellular magnesium low? Does someone have a thyroid issue? We will see people who have antibodies to the thyroid receptor, thyroid stimulating immune globulin, and they have a full-blown Graves, even without the eye changes. So those are right up front, we can get those things while we're saying, I'm going to refer this person. Now, the individual who comes in and says, oh, occasionally I have a skip and a jump. Occasionally I have a short burst of something fast, or I go to sleep at night and I lie on my left side and I feel my heart's racing a little bit. Most of these we can manage in the primary care setting. Again, you want the echo, because the echocardiograms can tell you, is this a structurally normal heart, or is this heart not structurally normal? If you find somebody's got an anterior wall that's down from an MI, or, you're obviously going to look at an EKG in all situations. But when you see that echo has a wall motion abnormality, straight to cardiology. But if the echo looks like it's preserved ejection fraction, you might just say, okay, let's check you for sleep apnea. Let's check your electrolytes. Let's clean up your diet. Let's get you off the caffeine and the dark chocolate and all the good stuff that causes arrhythmia. And let's put you on some magnesium. Chelated magnesium for me is a magic bullet for people with simple arrhythmias, APCs, VPCs, short runs of supraventricular tachycardia. I also use potassium analogs. Potassium at 3.5 is not normal in arrhythmia. I want to keep that potassium 4 or above. And hydration is very important. So I go through the whole list of things. Is it biochemical? Is it electrolyte related? Is it sleep apnea? Is someone eating too much dark chocolate, drinking too much caffeine, eating too much sugar? Is it structural? Is the echo not normal? Is it dehydration? Is it food sensitivity? So you sort of have to peel it away once you know you're on safe ground. No one will ever fault you for referring to a cardiologist. You'll never be faulted for that. You'll only be faulted for not referring.
Okay, perfect. So I'm going to say it back for everybody, and let's just make
Good
sure
luck.
that we're on the same page. Okay. So somebody walks in, maybe the first thing I want to know is, in the history and in the review of their past medical history, I'm looking for people who have potentially had structural damage, like a previous MI with a wall abnormality. If I'm not sure, I would definitely order an echo. Obviously, we're going to order an EKG to be able to just evaluate just frank arrhythmias right there. If they say, oh, yes, I faint with this, or I'm having shortness of breath or chest pain, these are strong indications to get on the phone with the specialist and then determine the next course of action. You may or may not, as the PCP, be motivated to then, based on what you and the huddle decide with the cardiologist or EPS doc, who's going to order the stress test or the echo or the monitor, but somebody needs to be evaluating imaging. And then perhaps if there's let's just say it isn't an acute need to get in, like the fainting happened a week ago, but they feel completely fine. From a functional medicine perspective, then you're saying start digging around the matrix. Like, number one, see if they've got sleep apnea. Number two, just see, like, when you're looking at that echo, what's going on with the structural integrity of the heart. Are they having biochemical deficiencies or excesses, right? So deficiencies like magnesium and potassium, or excesses like thyroid stimulation or autoimmune thyroid stimulation. It could be iatrogenic from somebody deciding to take more thyroid replacement. I know that's happened a couple of times because people want to lose weight. So they're like, oh, let me just double my thyroid medicine. The other one you mentioned is looking at assimilation and seeing if there's some sort of food interaction that's then creating an inflammatory response that could then trigger, like acid reflux can sometimes trigger this sensation of palpitations, shortness of breath, etc. And then the other thing that I believe you mentioned, or at least if it wasn't during this conference, it was in a previous one, is dehydration. just dehydration could be a reason. And that could happen either just from not drinking water, or maybe having these stimulants like caffeine, dark chocolate, etc. So I think that was there anything that I missed in the recap, Mimi?
I'd like to you did great. You're terrific. I'd like to add one thing that I think would be helpful. If someone says I get dizzy and lightheaded, what is the setting of that? The person who says I jump out of the chair and I feel dizzy or lightheaded, that's almost always blood pressure related. That's usually not arrhythmia related. The person who's eating their dinner and passes out at the table while they're sitting, that person needs a pacemaker until proven otherwise. The person who turns their head and faints probably has something going on with carotid bulb, sixth sinus syndrome. The person who shaves or tightens I have to tighten up my tie, and they faint. These people all probably need a pacemaker. So those are also other red flags. And one of the things I want to add, in the functional medicine, integrated medicine community, we all love to use active forms of thyroid, like active T3, whether it's in the form of Cytomel or it's Armor or WP or Nature-Throid. T3 can cause arrhythmia.
Yes.
And it's really important that we recognize it, and don't be afraid to pull it back if you think that's what's causing the problem.
Awesome. And so let's move on to Yusuf. Yusuf, I think I might ask you, and I apologize, apparently we're spending way too much time on these other lectures. So Yusuf, quick and dirty, can you tell me how you differentiate cellulitis versus stasis dermatitis from venous insufficiency?
Yeah. And I think this is something we see often. There's a clinical component, but sometimes it's very hard to tell. One of the things that I will do is I will start an antibiotic and I will work on venous insufficiency at the same time. Sometimes give them a little bit of a steroid, and a topical steroid usually first, and then I'll check a CRP. If the CRP is elevated, then that's a good indication that it was, depending on how high, that it was infection.
Okay, great, because I do think that sometimes they can look so similar. Now, here's this other problem that I encounter in just day to day. Like it smells like venous insufficiency. It talks like venous insufficiency, but then when I do the physical exam, it doesn't quite look like venous insufficiency. So how do I know it might actually still be venous insufficiency, even when the physical exam doesn't really give me the confirmation?
Yeah, so sometimes patients will have this sensation of swelling, but when you examine their hands and their legs, there is no swelling. The other thing is muscle cramps that you've optimized their magnesium, you're working on their gut, nothing is helping, nothing is getting better. Sometimes I'll put them on these supplements that help with venous insufficiency, and that goes away. And there's one more thing, when this is kind of like a pearl that has to do with the venous system. If you look at what causes what's the name of the trigeminal neuralgia. So if you look at the pathogenesis of trigeminal neuralgia, it seems like that there is a varicose vein that is coming out of the same exit that the trigeminal nerve is at. So I found that when I give those patients supplements to help tighten up the veins, that their trigeminal neuralgia gets better.
Ooh, cool. That's like a superhero move.
Da-da-da.
Da-da-da-da. Put on your son's tie. Okay, that's an internal joke, everybody. Awesome. These are great clues. Thank you so much. So Yusuf, what about, you mentioned earthing. Now that's one of my favorite things to talk about. And I think it's like a little bit of a nice little functional medicine powerhouse kind of tool. Can you tell us a little bit more about earthing and how you use it? And then maybe Michael and Mimi can also share.
Yeah, I have put my foot in my mouth so many times in my career, and I stopped making too many comments because earthing sounded like something so hippie, until one day I had this patient who had diabetic ulcers that we were given antibiotics. She was going to the wound center and nothing would get her better. And finally I'm like, look, don't tell anybody that I said this, but there is this concept of earthing where if you put your feet on the ground, earth has this negative charge and it may have healing properties. So don't tell anybody that I'm telling you to do it. Just what I want you to do is take 2 weeks, go outside. You can have your socks on, put your feet in the ground and just sit there. You can be in the shade and come back in 2 weeks. I took pictures before.
In the ground or on the ground?
On the ground. Yeah,
Okay,
not in the ground, on the ground, right on the ground.
Here, you do not have to dig a hole for earthing.
You don't, no, but dig a hole, it's better, go deeper. But what the cool thing is she came back and like the ulcers closed up and the color got better. And I'm like, okay, my foot tastes not too good. I need to, I don't know, spice it up with some hot sauce.
No, there's a lot of ancient, at least, mention of grounding. I mean, just the yogic tradition has you use a cloth when you do yoga. A lot of times when we're using plastic between us and the earth, we're blocking the ability of our bodies, which are 70% water, to conduct the electromagnetic field that is in the earth. That's not like woo-woo, that's science still. I just want you to know. It sounds like it's woo-woo, but it's absolute. If you look at the science behind heart math, it's very similar in concept of this bioelectromagnetic field. So Moses was told, you're in a holy place, take off your shoes. Maybe he needed to earth, right? And if you look at in the Bible, Jesus put his head on the ground and prayed. And in the Islamic faith, you put your head on the ground and to pray. What if that's opening up this chakra here, right? The electric charge. Ancient coming around, proven by modern. I mean, it's just like my grandmother used to shove turmeric paste in my throat when I was sick. And I thought, what are you doing? And then, of course, 30 years later, there's all this evidence about turmeric and ginger and capsaicin and all the things that were medicinally used by uneducated women of the village. So, okay. So Mimi and Michael, anything else to add about earthing, grounding, heart math, any of that stuff for the heart health?
Well, I think we know that the heart is an electrical field that extends out about 15 feet from the body. And if you want to do an electrocardiogram, you put electrodes on the legs, out on the arms, and you say, gee, how is that picking up the heart? Well, the heart's electromagnetic field is much larger than just this. And of course, the heart math research teaches us that the heart is much more than a pump. The heart recognizes things, sends messages via the vagus nerve to the brain. And to me, it's very, very powerful medicine. So
why not? And it's cheap, it's free. The side effects are
exactly.
Just don't put your feet on a pile of fire ants. I mean, that's the side effect if you don't pick the right part of the earth.
But it's also the connection to nature, right? Yeah. It's being out in nature. It's being close to the trees and the earth and breathing in the ions of the ocean. And it's all connected.
It's a tuning fork. Get connected, not to your Wi-Fi. Get connected to the earth. Like, Wi-Fi, unfortunately, is what I'll call anti-earth.
Yeah, look at the different frequencies that we are and the fact that even our mitochondria, when there's dysfunction, we release fewer biophotons per second as we have mitochondrial dysfunction. The amount of energy that our heart and our beings emanate really is markedly affected by everything, including whether you can get your feet on the ground and earth.
So does anybody else have the aluminum foil hat, or just seeing if I'm alone? Or...
Well, listen, I just want to close out our Q&A with this principle that everything is not always biochemical and structural. And just to say that I can't tell you how many times I feel like I've got all the biochemical and structural and communication, all that kind of node stuff seems like locked up. But that middle of the matrix, the mental, emotional, social, I'll call it spiritual in there too, that is the missing link. And I think we sometimes forget that there's things beyond the body that are not in the human ecosystem, I should say in the human body ecosystem, but those things that are outside in the ecosystem that have tremendous impact on the ability for your functional medicine therapies to stick.
Absolutely.
Yeah.
We agree.
All right. So put your head or knees or feet down on the earth, find some earth. We are going to now actually be grounded in the science of homocysteine. So, Yusuf, you've got another, I wouldn't say dense because it's just Yusuf's ability to understand deep science is lovely. That's why we love having you as part of the team. You're going to really delve into this homocysteine subject because I feel like MTHFR and homocysteine is definitely associated with heart health, but people get confused many times on how to untangle that story. So I'm excited about you to talk about that. And then we're going to have Michael Stone talk about the other hot topic that we cannot ignore, which is the COVID-19 and its impact on cardiometabolic and cardiovascular health and how to use functional medicine to keep that heart and body safe in these times.